Good morning, everyone. Today, in this series of urology exam preparation, we are going to discuss the various scenarios possible in urological infections. We have got a trainee here who has volunteered to take part in the discussion. Welcome.
Good morning, Mr. D. And I'm happy to record this and spread it in the social media for the purpose of revision and training and for the benefit of the future trainees. Thank you so much.
Thank you very much. That's very kind of you. Let's dive into the scenarios.
Mhm.
You have a 22-year-old female, wheelchair bound, with past history of multiple sclerosis, brought to your clinic by the carers. The main concern is her urine is quite smelly, and at times she is quite agitated. And when the nursing home team did a urine dipstick, it showed plenty of nitrates and leukocytes. So they think the UTI is the reason for all her problems. How can you help her?
I'll see her in the urology outpatients along with her carers. The main points, I'll plan my consultation like history taking, a chaperone assisted examination, and doing the basic investigations. If she's um, if she has got capacity, I'll take the history directly from her. Um, I'll see whether she has got any previous culture-proven UTIs, whether she is symptomatic now, how frequently her catheter needs to be changed, whether there is any history of catheter blocks, any uh, red flag signs like hematuria or admission in hospital due to infection, um, and any previous history of ITU admissions because of the urinary problems. And in the past history, I'll see oh, her medical history as how long she has been having this multiple sclerosis for, and what was her condition before the multiple sclerosis, whether she had recurrent infections before that as a child. Has she got any other associated comorbidities like diabetes or whether she's on any steroids that can increase the risk for her recurrent infections? In the surgical history, mainly to see whether she got any previous urological histories like stones or urology instrumentations. In the uh, lifestyle history, I'll mainly look at and see how her fluid intake is like. And uh, with this with this history, I'll make sure my main aim is to see whether there is any recurrent culture positive UTIs that has caused her acute or chronic deterioration because the history says that she is agitated and her urine is smelly. This will be followed by a chaperone assisted consented clinical examination, mainly concentrating on the general examination to see her performance status, her BMI, and her general well-being, mainly to see whether she has got her body has got the capacity to fight off infections. A examination for the loins to see if there is any fullness of the loins, any suprapubic tenderness, to make sure whether the catheter is suprapubic catheter or a urethral catheter. Examination of external genitalia to mainly to see if there is how's her local hygiene is, because patients on urinary catheters can have troublesome excoriations of the local area that can be troublesome for the patients. And if it allows, I'll do a internal vaginal examination, mainly to make sure that there is no urethral diverticulum or any vaginal masses or any tenderness or any abnormal vaginal discharge. I will go through the basic investigations. My main aim will be to see a dipstick urinalysis, mainly to see whether it is positive for leukocytes, nitrites, and blood, which might be suggestive of a UTI, but it could be confounded by the presence of a catheter. I'll definitely send a urine sample for culture. I'll go through the previous records to see how many urine cultures were positive over the past 6 months or 1 year, whether um, it, it was positive for bacteria and what type of bacteria was grown in the cultures, especially to see if it is urease producing bacteria. Afterwards, I'll do a outpatient bladder scanner to make sure that her bladder is emptying properly and there is no block of catheters. I'll make sure that her urinary catheter is changed recently and the urine output is clear. And I'll make arrangements because she has got smelly, agitated urine. So I believe this could be a symptomatic UTI recurring again and again. So I will arrange for a outpatient ultrasound urinary tract, mainly to rule out possibility of any stones. So this will be my approach to her.
Okay. What do you mean by multiple sclerosis?
Multiple sclerosis is a debilitating neurological disorder where multiple plaques can get deposited in the spinal cord, and it can appear like there are different phases of multiple sclerosis, and there are varied presentations as well. So depending on the site and the density of the plaques deposited, it can range from a quiescent type of disease, and it can to that other extreme where patient is severely debilitated and wheelchair bound. Even some of the multiple sclerosis patients can have the presentation like initially with urinary tract symptoms.
Okay. You discussed about the urine dipstick in a patient with a catheter. What are the pros and cons?
Because of the bacterial colonization of the catheter, most of the time the urine dipstick will be falsely positive in a patient on catheter. So there's a concept of asymptomatic bacteriuria where we don't have to treat even if the urine dipstick is positive and the patient is asymptomatic, but a combination of urine dipstick positive and symptomatic patient on catheter, we can consider that as a possible urinary tract infection on catheter and then treat it with empirical antibiotics.
Why there is a very big move to stress that asymptomatic bacteriuria should not be treated with antibiotics, especially in elderly women? Why is that?
This was because of the concern of bacterial resistance developing, because in previous years, there was no culture or anything needed to prescribe antibiotics. And there was a concept like on elderly women, the urine dipstick was not reliable. And also, if elderly woman presents with confusion or agitation, UTI has to be excluded. This led to the prescription of antibiotics without culture positivity, but in turn, it produces some collateral damage where there was a lot of resistance developing to antibiotics, especially for fluoroquinolones. And then the concept of antibiotic stewardship were put forward, where it is a concept where the carers or the care providers got the responsibility of making sure that the antibiotic is needed. So we had to make sure that the patient has got infection. We had to make sure that it is culture positive before prescribing recurrent antibiotics. So in altogether, the aim is to prevent antibiotic resistance from happening, at the same time providing the best care to the patient and also taking the cost effectiveness into account.
Okay. So what precautions you will take when you need to collect a clean urine for cultural sensitivity in a patient with a catheter? How can you do that?
Yeah. If the catheter shows any signs of chronic infection, like if the catheter is heavily encrusted or if there is any purple color, you have to change the catheter. And during the insertion of a fresh catheter, we can take the sample from the catheter itself. But if the catheter is only recently changed or there are no signs of infection, we can use the catheter sample port to collect the sample of urine.
Okay. The other easiest way, as you said, is to just put a fresh catheter so that the catheter is sterile and the first urine coming out of it will be almost equivalent to the clean catch midstream urine. And catheter port are present in only some brands of catheter, but that's a good source. But even then, it should be used only if the catheter is relatively new. A
Yeah.
catheter, once it is placed, whether it is SPC or periurethral, will get infected within few hours, and 100% it is getting contaminated within 24 hours. The
Mm.
only difference between the suprapubic catheter and urethral catheter is the chances of significant infection episodes is relatively less in suprapubic catheter, since it is away from the genital organs and especially the rectum and anus, which is the main source for the E. coli infection.
Yeah.
Okay, this patient's urine culture, which you have sent, has grown E. coli 10 to the power of 6, sensitive to all the antibiotics. How are you going to progress now?
So because the patient is symptomatic, because I'll take the agitation and confusion that has developed recently as possible sign of UTI, and the culture has shown significant growth of bacteria, most common which is E. coli. So I consider this as a possible catheter-associated UTI, and then will give her a prescription of an empirical antibiotic. Either I'll make sure that her uh, urine, her renal functions are normal by going through the blood test, and I'll give her uh, 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 nitrofurantoin or trimethoprim because it's sensitive to everything. My choice of antibiotic will be trimethoprim, 200 milligram twice daily for 3 days. Sorry, because I will consider this as a complicated UTI because of the presence of catheter. So I'll give her antibiotics for 7 days.
Okay, what kind of catheter care you are going to give her? Say, for example, before starting the antibiotic, her catheter may be completely infected with E. coli.
Oh,
Your
yeah, definitely.
antibiotic may be, yeah, your antibiotic may be very good in treating the actual UTI, but it
Hmm.
can't fight against the foreign bodies with contamination. And we know that foreign body will be like a nidus for the infection. So how you are
Exactly.
going to take care of your catheter?
Yeah, sorry for that. So I'll make sure I'll ask the carers when was the catheter changed, and if the catheter was changed within the last 7 days, then we don't. Nice guideline says that we don't have to change the catheter, but can start with the antibiotics. But if the catheter was changed 7 days prior, then it is a good practice to change the catheter and then start the treatment because the catheter is known to harbor the biofilm, so the antibiotics will be difficult to penetrate in the presence of a foreign body that has got a biofilm over it. Definitely, if the catheter looks encrusted or with lots of infection, or if the catheter has been changed more than 7 days, then I'll change the catheter along with prescribing the antibiotics. I'll give instructions to the carer to make sure that her fluid intake is adequate and to make sure that her local hygiene is also maintained during the uh, treatment of this episode of UTI.
Take me through about E. coli. Why E. coli is the commonest infection pattern, especially in women, and what do you know about the virulence factors for E. coli?
E. coli is the bowel bacteria, and because of the proximity of the bowel, the um, large bowel to the urethra, that's the reason that E. coli is the most common bacteria in UTIs. Also, in females, the urethral length is on an average 4 centimeter. So that also makes it easier for the bacteria to get access to the urinary tract, bladder. Uh, E. coli has got these virulence factors, especially the uropathogenic E. coli is known to have virulence factors that helps it to adhere to the urothelial epithelium and then propagate from there. The virulence factors of E. coli can be fimbrial or bacterial, and depending on it's called pili, and there are two types of pili, type 1 and type 2 pili. Type 1, which is the manosensitive pili, is most commonly associated with cystitis. What happens is with the type 1 pili, the E. coli is able to adhere to the epithelium, in the bladder epithelium, and then the receptors in the bladder epithelium, I believe it is uroplakin, that receptors help to anchor the type 1 villi to the membrane. And it is very, once it is anchored, it can incite an inflammatory response, which will manifest as infections from the host, infections to the host, the host response to infection. So these virulence factors can help the E. coli to adhere much more efficiently to the urinary tract. That's the reason that it is difficult to treat once there is an established infection of E. coli.
Okay, so as I said, the patient has grown E. coli and you have treated the patient with antibiotic. And is there anything you can do more than antibiotics? What kind of advice you will give to the carer?
There are lifestyle modifications that we can try, where we can increase the fluid intake, make sure that the local hygiene is preserved, make sure that whenever the local area is wiped, it is wiped away from the vaginal introitus. And if there are any reversible risk factors like diabetes, we have to control that. And also, if she's on steroids, we can request the GP to reconsider the option. And also the catheter drainage. I'll make sure that the catheters are, the carers are following the closed drainage system of catheters. So this will be the, regarding the, there are other non-bacterial measures that we can take to improve the recurrent UTIs. One of them is cranberry products. Initially, the Cochrane review showed that there is an effect of cranberry products to prevent the recurrent UTIs. However, an updated review suggested that there is not. So the exact role of cranberry products on preventing the recurrent UTIs is still controversial. But the further sub-analysis of the Cochrane review has suggested that if the product has got the main active ingredient, proanthocyanidin, at least 32 milligram or even to the level of 76 milligram, then that should be good to prevent recurrent UTI. So if you are using the right products, then it can prevent recurrent UTI. So in her case, I would suggest to try for cranberry products, which has got the active, adequate active component. Other measures I can try, which has not proven much benefit, will be to give her D-mannose, but I'll make sure that she is not diabetic and her diabetes is controlled before giving the D-mannose. So these will be the other measures that I will suggest to improve her recurrent UTIs.
So she has got, let us assume, a urethral catheter. What is your view on suprapubic catheter versus urethral catheter in a wheelchair-bound multiple sclerosis patient with recurrent UTI?
So the advantages of a suprapubic catheter are, one, the easiness with which the carers can carry the catheter, and the catheter is sited away from a potential source of infection, the bowel. And the long-term presence of a catheter in the urethra can cause urethral injuries and can produce traumatic urethral, there's traumatic sphincteric incompetence that can lead to continuous leak of urine from the bladder. So for these reasons, for patients who need a long-term catheter, we tend to advise suprapubic catheter, making sure that she has got no previous abdominal surgeries. There is no risk factors of any bowel injuries that might happen during the procedure. So in those cases, in her case, because she is multiple sclerosis, I believe, which is a disease which is in many sense, which is irreversible, a suprapubic catheter is a good option for her.
Okay, good. So you're prescribing the trimethoprim long-term course because of the, extended course because of the complicated UTI. You're giving all the advices to the carers on catheter care and UTI prevention protocols. How are you going to follow her up?
So I will make arrangements to see her back in 3 months' time initially. and make sure that the low-dose antibiotic prophylaxis is working. I'll see was there any breakthrough UTIs while she was on low-dose prophylaxis, whether she has had any admissions during the procedure, whether her catheter is draining clear and staying long without any blocks, and will repeat her bloods to make sure that her renal functions are remaining stable. So this will be my approach when she comes back for the review in 3 months' time.
Is there any role for imaging the upper tracts?
Definitely. For a patient with multiple sclerosis, my main concern will be the ineffective drainage of the urinary tract. So in which case, if she's symptomatic, I'll definitely arrange for an ultrasound urinary tract, mainly to look for any stones or any hydronephrosis, or possibly because of the recurrent UTIs, there could be even possibility of shrunken kidney. So for these reasons, I will arrange for an ultrasound urinary tract to look for the kidneys.
Okay. The ultrasound shows bilateral PCS mildly dilated, but there is no signs of any obvious infection or stones, and kidney cortex seems to be quite adequate. Corticomedullary differentiation well preserved, renal functions normal. Any changes you need to do? What is your follow-up?
All right. For I will be concerned with that mild dilatation of the urinary tract, but as long as her renal functions are remaining stable, my plan will be to continuously monitor her. I'll Okay, and then I'll monitor her subsequently with repeat UCNIs and a repeat ultrasound scan in 3 months' time. If there are any concerns of increasing bilateral hydronephrosis, or if her renal function is deteriorating, if her creatinine is going up or if her EGFR is coming down, then I will suspect possible high pressure, overactivity of the bladder, and in which case I have to make sure that it is not a high pressure reservoir that can damage the upper tracts. So if it's deteriorating over time, I will make arrangements to start her on relaxing anticholinergic medications to relax the bladder and see if that improves her hydronephrosis. If not, then I will definitely make arrangements for a urodynamic study to make sure that there is the upper tracts, the storage urinary pressure is below the 40 centimeter of water, so that the upper tracts are still protected.
Okay, so the main things are the mild dilatation of PCS could be a physiologically normal sign, and also it can present with coexisting bladder, etc. So sometimes this cannot be a pathological finding. As you said, serial monitoring will help. You are reviewing the patient in 3 months' time, and patient seems to be fine, but there are some episodes of intermittent blood tinge in the urine and some episodes of confusion, and whenever the carers do a urine dipstick, it throws up leukocytes positive, nitrates positive, etc. What is your advice, and what other follow-ups you need to do?
Because even after doing all these precautionary measures, she is still having recurrent UTI. So I'll review her urine culture and sensitivity and see if this is like a persistent UTI. That means if the still the same organism is causing the recurrent infections, in which case I will suspect a nidus of infection, and like a possible from the bladder part, it could be a diverticulum, or in the kidney part, it could be a stone in the kidneys. So if this is persisting, I will make arrangements for further investigations in the form of a cystoscopy, outpatient local anesthetic flexible cystoscopy, and ultrasound scan to see if there is any evidence of urinary calculus or even secondary findings like hydronephrosis.
Okay. You are arranging a flexible stethoscopy, which showed kind of high-colored, cloudy urine in the bladder, but otherwise no specific findings noted. Our follow-up ultrasound is also stable, no evidence of any progression in dilatation of pelvic alicer system. Renal functions were stable. Is there any role for prophylactic antibiotics for this patient?
Yes. If the recurrent UTIs are affecting her quality of life, then definitely, and we have ruled out any red flag signs that can cause the persistence of UTI, then there is definitely a reason to give her a low dose antibiotic prophylaxis. The studies has proven that low dose antibiotic prophylaxis, on one hand, the advantage is it can improve the occurrence of recurrent UTI by up to 80%. But on the other side, the main concern is development of resistant bacteria. Because she has got recurrent symptomatic UTI, I will advise her to try low dose antibiotic prophylaxis. And depending on her culture and sensitivity, I'll prescribe her the low dose antibiotic, and will advise her to take it for 6 months and see if that can prevent her recurrent UTIs. If it prevents her recurrent UTIs, I will continue it for 12 months, and then I can try for a trial period of stopping the antibiotics, because on low dose antibiotic prophylaxis, once we stop the antibiotics after 12 months, there are studies that has proven that in 50% of the patients, the recurrent UTIs might not recur. The reason being the low dose long term antibiotics has cleared of any bacterial inoculations or any nidus of infection. So that will be my plan for her if her UTIs recurs in spite of all the conservative and preventive measures.
Good. Your answer is quite correct for a normal female of 20s or 30s presenting with recurrent UTI. But just be very cautious of the catch. This patient is wheelchair bound, multiple sclerosis on a catheter. So on a patient with catheter, the role of low dose antibiotic is quite questionable, because you're not going to be successfully eradicating E. coli from her system. It is almost impossible. And by giving low dose antibiotics, the chances of antibiotic resistance is quite high. So you need to be very cautious, and you have correctly placed your answer discussing both the pros and cons. But when you are discussing the cons for low dose antibiotics, bring in the long-term catheter situation. That will be very handy. Okay. This patient becomes a little bit stable, and as you said, she had low dose antibiotic for 6 months and then discontinued, no further episodes, and almost for 12 months, things have gone well. After 12 months, your registrar calls you, you are the on-call consultant, saying that the patient known to you, multiple sclerosis, whom you had previously treated for recurrent UTI, is now presented via A&E in a very unresponsive state, and the A&E doctors have resuscitated and done whatever they initially need to be done, and their working diagnosis urosepsis, and they are asking you to review. The registrar on call is a very early stage ST3 trainee, let us assume, so you're going to lead the show. What is your approach?
So my I'm concerned about the possible pyelonephritis in this patient because she's in A&E. So I'll consider this as a urological emergency. I'll go to A&E as soon as possible and then review the patient, make sure that her resuscitation is being done following the ALS protocols. Also, the sepsis 6 protocol is followed. And once she is stable, I'll do a focused abdominal consented chaperone assisted. I'll make sure that the A&E team is also involved. We'll do a abdominal examination to make sure that there is no suprapubic tenderness, there is no retention of urine, and also the loins to see for any tenderness or fullness. And then if her condition is stable, I will arrange for a imaging, and my choice of imaging, if she is really unwell, and will be a CT scan. and I'll contact the radiology on call and see if a CT scan can be arranged as soon as possible.
Okay, good. You mentioned about sepsis 6. What do you mean by that?
Sepsis 6 was an initiative implemented to improve the outcome of the patients coming to hospitals with in sepsis conditions. It involves 3 therapeutic modalities and 3 diagnostic modalities. The 3 diagnostic modalities involve taking bloods for FBC, USNEs, CRP, LFT, and coagulation, and then blood and urine for culture and sensitivity, and monitoring the urine output hourly. And the 3 therapeutic modalities are giving her a broad spectrum antibiotic within 1 hour of admission, and IV fluids, and also sorry, in the diagnostic modality, we had to look for the lactate level as well, to make sure that the lactate to see if the lactate is more than 2. And yeah, these are the sepsis 6, 3 the therapeutic modalities and 3 diagnostic modalities. And we had to make sure that all these things are done within 1 hour of admission.
Okay, good. There are very good, strong evidences to support sepsis 6 and how it helps us to identify sepsis at a quite early stage. Not only urological, it can be also spread to the other specialties. How I easily remember the sepsis 6 is, I'll start from head to foot. First is the oxygen. So giving oxygenation, and then second is placing an IV line. And when you place an IV line, you can take the blood for culture, that is the second one. And third one, you can take the bloods for the normal blood, FBC, everything, including lactate. The fourth one is you can give the antibiotics through the same Venflon. And fifth one is you can finish the IV line placement work by starting an IV drip. And the last 6 one is the urine output monitoring. So the easiest way is start from top to bottom. The first one is like starting an oxygen. The last one is placing a catheter. In between, the 4 comes with the IV line. So IV line placement, and you are taking 2 things, one for blood culture, one for bloods, mainly concentrating on lactate. And 2 things you are giving. One is the antibiotic first, and also the IV drip, so that you are completing the IV line placement. So it's a very easy way to remember. The way by which you are remembering is correct, but you missed the oxygen, which is also equally important.
Yeah, sure.
Okay, good. Is there any scoring system you are aware of when you want to closely monitor the patient?
Yeah, so we follow the National Early Warning Score System, which has proven to, it's a track and trigger response system where serial monitoring of the observations are done, and depending on the score, the responsible team is alerted. And the scores that we look for is the respiratory rate, saturation, heart rate, blood pressure, level of consciousness and temperature, and also will give an extra score of 2 if the patient is on oxygen. And depending on the score obtained, we divide it into 3 types: the low score, where it is 1 to 4, the medium score 5 to 6, and the high score more than 6. When the score these are monitored by trained nurses, and the instructions given are, if the score is 1 to 4, the advice is to repeat the observations more frequently, and the team has to inform the nurse in charge. If it is a score 5 to 6, then a specialist trainee for the patient is responsible should be involved in the care. And it's also advisable to reach the outreach team if the patient is continuing to deteriorate. If the score is 7 or more, then it is important that the outreach team or the ITU team has to be contacted immediately and make sure that the patient is reviewed by the ITU team.
Okay, you're doing the CT scan for this patient as we planned. You got 2 pictures, picture 1 and 3 or the CT scan. Could you read this for me and also share it, please?
So I can see two pictures here. One is the axial image of CT scan of abdomen. It is
Click once to
showed,
magnify it, please.
yeah. So this is, yeah, this is showing dilated, enlarged left kidney with the contour of the kidney preserved. There is no perirenal fluid collections I can see. The right kidney appears normal in size with adequate, sorry, this is a contrast enhanced CT. I can see the contrast in the arterial phase. And so the right kidney is adequately perfused. And in the coronal section, I could see that the left kidney, yeah, I confirm my axial scan, axial cut findings where the left kidney is dilated, obstructed, but still there is no fluid collections. I can't see the ureters in this cut, and in the bladder, sorry, ideally I would like to come see the full picture, the full series of the CT to see. My main aim will be to see if there is any stones that is causing this obstruction, and for me, and also if there is any fluid collections around it, and to see the status of ureters and bladder. For me, this appears like the bare sign of XGP, but I'll be very cautious to make the diagnosis in the absence of a stone. But it is in rare occasions, XGP can occur even without stones. So that will be my interpretation of this this CT scan. Mr. D, can you hear me?
You can stop the share steering now. That's
Oh,
good.
yeah.
Okay, good. So the findings of XGP is very important, and also you are aware that it could be due to a nidus like a pathological kidney, PUG obstruction, or could be a hydronephrotic kidney, pre-existing some causes like stones. Those can present. Now, let us assume that her bladder is collapsed due to the presence of the catheter and no other major pathology is noted. So what is your plan?
I'll make sure I'll review her and see how she is progressing with the resuscitation. If she's progressing, if she's responding well to the antibiotics and fluids, then my plan will be to continue the antibiotics. I'll liaise with the microbiology team as well to make sure that we are giving her the right antibiotics based on her previous culture and sensitivities. If she's progressing well, then I'll monitor her. I'll make arrangements to transfer her to the ward safely and then continue to monitor her. My plan will be to do continue the observations, repeat the bloods later, and make sure that the inflammatory markers, if it is raised, if it is coming down, and if once the patient is stable, I'll review the images with my radiology team to see if there are any other abnormal findings, like surprising findings, like any tumor or anything is seen in the kidneys before making the further plans. If it is purely obstructed kidney, and if her general condition improves with the conservative measures, I'll have a discussion with the radiology team and see if citing a nephrotomy and decompressing the system might be adequate to improve her further current clinical situation of sepsis. So I'll plan like that, and the further plan will be based on her further clinical improvement or deterioration.
Okay. Do you know any types in XGP? It is not a
Right.
very commonly practiced staging system, but there are stage 1, 2, 3. Stage 1 is more of involvement of pelvic system. Stage 2 is involvement of the renal parenchyma, and stage 3 is involvement of the neighboring organs like perinephric inflammation and sometime involvement of the large bowels, etc. But it's not very commonly used anyway.
All right.
Then let us assume that patient is not improving. You're doing the sepsis scripts and you're keeping the patient on antibiotics. Having said that, what antibiotics is your choice?
I'll give her a combination that can cover both gram positive and gram negative. My antibiotic choice will be gentamicin, 5 milligram per kilogram, and then also a third generation cephalosporin, cefuroxime, 1.5 gram IV.
Okay,
So I'll
the
give
other
this.
possible, yeah,
Sorry.
go ahead, please.
So I'll give the option like to continue the antibiotics and review her response in 48 hours. And by that time, I'll get the culture and sensitivity report, and then I'll tailor the antibiotic need according to the culture and sensitivity report.
Okay, the blood culture has grown E. coli sensitive to most of the antibiotics, no specific resistive patterns, including piperacillin-tazobactam. Piperacillin-tazobactam is one of the commonly used broad-spectrum antibiotic, which has much more coverage compared to individual gentamicin and third-generation cephalosporins. But there is nothing wrong in the answer. We want to give broad-spectrum. That's the main key of the treatment protocol. The patient is not improving. You are giving adequate antibiotics. She is having episodes of fever and scoring news. And after 48 hours, she still has some spikes of temperature. What is your next stage?
So in this situation, the clinical picture is pointing towards ongoing inflammation of the kidney. And because the concern here is a XGP, I'll have a discussion with the anesthetic team to see if the patient will be fit for a anesthetic procedure, a major anesthetic procedure like a nephrectomy is feasible for her or not. If she is still unwell, the diagnosis is XGP, and if the anesthetist agrees that she can undergo a nephrectomy procedure, I'll have a opinion from one of my senior consultant colleagues as well, and then we'll decide to go ahead with a nephrectomy if the patient is not improving with the antibiotics. If she's really unwell, she's unfit for any surgical procedures, then one of the options is to try to put a nephrostomy and see if that can improve her clinical condition. Having said that, the insertion of a nephrostomy in conditions of XGP is very unlikely to improve the symptoms because it is multiple dilatation of multiple calcium system. But if the patient is not fit for a major procedure, then we can try the option of a nephrostomy as well to see if that improves her clinical condition.
Okay, what is the difficulty in nephrectomy in XGP? How it differs from any other simple nephrectomy or radical nephrectomy which you may have come across?
So XGP is a very much severe inflammatory condition. So there could the main problem that we can face with doing the nephrectomy is the adherence of the inflammatory planes to the surrounding structures. So once we put the incision and open for the nephrectomy, there is a very good chance that we might really find it difficult to find the correct plane. And also there is an increased risk of injury to the bowel and the surrounding organs because of the inflammatory response. So it is considered as a very high risk procedure doing a nephrectomy in a XGP because of the mainly regarding the injury to the surrounding structures.
Say you are quite trained for laparoscopic nephrectomy. So what is your plan, laparoscopic or robotic assisted laparoscopy? What is your plan for the approach in nephrectomy for this patient? Do you plan laparoscope or what are your steps?
I will be reluctant to do a laparoscopic nephrectomy in a case of XGP if the patient is unwell, because the first thing is that we have to, there is a need for intraperitoneal gas and the distension of abdomen during the procedure, and that can adversely affect her vital parameters. But having said that, if she's at least stable with antibiotics, and with this picture where there's no perinephric fluid collections, and if there is an expert who is available for the laparoscopy, there are studies which says that laparoscopic approach, at least an initial laparoscopic approach to XGP is feasible. So for her condition, there's no perinephric fluid collections. So she can be a suitable candidate for XGP as long as the anesthetic team is happy to put her under anesthesia with the increased intra-abdominal pressure due to the gas insufflation. So if we can meet all these conditions, then a laparoscopic approach is feasible.
Okay. The main things what I will be interested is that there's nothing wrong in starting with laparoscope, but there should be a very low threshold for open conversion. That's number one. And also, even though by labeling it will be a simple nephrectomy, it will be a very difficult nephrectomy and much more challenging than any radical nephrectomy or nephrectomy which you may be doing. So there is a very high chance of infection spillage, injury to the neighboring organs, especially on the left side, means like spleen and descending colon and the splenic colic flexure. And the consent itself should be quite in detail, and that's just for the patient to end up in ITU and not able to extubate immediately, and patient needs to be ventilated and properly supported. All those factors should be discussed with the patient, including the possibility of the death. And can you please share the second picture, which is there in your screen share, please?
Yeah, so this is a histology slide. On the, I can see the arrow pointing towards a large cell with a dark nucleus. So on the background of clinical suspicion of XGP, I will consider this as a xanthoma cell, which is a characteristic of XGP, which are histiocytes with these are lipid-laden macrophages, which are characteristic of XGP. So this can confirm our clinical diagnosis of XGP. And also I can see a lot of inflammatory infiltrates of neutrophils around that. So this appears to be a really inflammatory condition, along with the classic picture of xanthoma cells.
Very good. So what are all the characteristic histology features in RCC? Is there any characteristic feature like this present in RCC?
Oh, yes, definitely, because this can be at the same. This can be a clear cell picture of the RCC. The clear cell has got a similar appearance of the xanthoma cells because of the clear cell. The appearance is mainly because of the glycogen content of the clear cells. So definitely, this warrants a discussion with the uropathologist and making sure that it is indeed xanthoma cells and it is not clear cells of an RCC.
So how will you differentiate? How pathologists can help you?
Pathologists can run the immunohistochemistry markers, and if it is, I believe CK. Sorry, I'm not exactly sure about the markers, but the team will be able to run the immunohistochemical markers that can differentiate between the RCC and the xanthoma cells.
Good. Yeah, immunohistochemistry is one method. There is also a stain available by name PAS, which stands for periodic acid strip stain. PAS stain is quite good in differentiating the foamy cells from the RCC's clear cells. Okay, that's good. You can stop screen sharing now. So this patient had quite a very stormy post-op period, required ventilation for 1 day, but gradually recovered and sent home on the 11th day post-op. She has then a comfortable course, not much urinary infections, but she's kept under the neurologist also for her multiple sclerosis. And let us complete the scenario here. What is your impression on the presentation? And do you have any questions on the scenario?
I mean, for my reflection, I think I need to organize my thoughts because when I realized one thing when you asked for sepsis, I missed the oxygen. I have to know in and out of sepsis, no doubt about it. And second thing, when you asked me about the surgical procedure, yeah, I should have definitely elaborated on that part. So yeah, I need more practice on how to answer a question from a surgical point of view. So that's my reflection of this training session.
Good. So as we usually discuss, don't make be very very strong in all the red flags things like infection, sepsis, where the patient could die. As I said, FOSS is an exam testing you to be a good independent year one consultant. And when you're on call on your own, you should be able to run the show independently. Of course, as you correctly said, before taking a patient for a nephrectomy, that to a very challenging nephrectomy, you should involve your colleagues, not only for an opinion and also to give a extra pair of hand. Those things are very good. Any questions you have regarding the scenario?
Yeah, two things. One, uh, is there a role for a nephrostomy in a very unwell patient and the clinical? Because I think that is a bare sign of CT scan, isn't it? So
Yeah.
if it is definitely XGP, is there a role for nephrostomy? Can I say that, or is it nephrectomy that is definitely indicated?
Yeah, you can say that you have played it quite clearly and you said nephrostomy, but also you clearly defended yourself that nephrostomy may not work if there is multiple calicial involvement. That's why the XGP staging may come very handy to you. So stage
Okay.
one means it's predominantly pelvis and collecting system involvement. Maybe in that stage, placing a nephrostomy will decompress the system. And once the system is decompressed, there is no increased intrarenal pressure that will allow fresh blood to flow into the system, which will help in bringing in all the anti-inflammatories and patient's own body defense system. And also it helps in relieving the pressure and taking out the thick pus, whatever accumulating, which is almost impossible for a crippled multiple sclerosis patient to defend on her own. But if you go to the second stage or third stage XTP, second stage means involvement of the renal parenchyma, and sometimes XTP usually is like upper pole to lower pole of the kidney. There is no focal involvement. And if there is extra renal involvement involving like thickening of the bowel or inflammation involving the momentum, then it becomes very difficult and chances of a simple nephrostomy to drain, it's quite rare. There are some small studies where the people tried even two nephrostomies if there is two focus of collections, but it all depends upon the stage in which the patient is presented to you.
All right, perfect. Thanks so much. And one more question: if this scenario is moving forward, like when if the examiner asks me in the follow-up, will I do a DMSA scan? Is it mandatory to the DMSA scan, or can I again follow up with imaging like ultrasound tract only?
You mean if the patient didn't ended up in
Improves
nephrectomy,
nephrectomy, improved.
definitely, yeah, yes. If there is the patient didn't end up in nephrectomy, recovered, definitely there is a role for DMSA because any patient who had such a significant episode of XGP, chances of having at least acceptable functioning kidney is very remote. So if the patient recovers with conservative management, you can do DMSA scan once the patient completely recovered and allowing the kidney to recover at its best so that we can document the function of the kidney. I don't usually believe in doing nephrectomy in a recovered asymptomatic patient, a simple nephrectomy to remove the non-functioning kidney. We can wait. But if that non-functioning kidney becomes the nidus for the recurrent infection, patient is symptomatic due to that, then we should do an elective nephrectomy if the DMSA function is say less than 20. Less than 10, definite nephrectomy. 10 to 20 is borderline, but more than 20, we should be able to preserve the kidney as much as possible. This is a systematic conditions, multiple sclerosis, and beware that patient's opposite kidney may also prone to the same amount of infection, same etiologic factors, and same decreased patient's defense system. So just like that, making the patient into a solitary kidney patient, we're not helping. We need to preserve the nephrons as much as possible. So elective nephrectomy, if the nephrons or the DMSA shows function less than 10 or borderline 10 to 20, but if the patient is recovering well, we can hold on.
Thank you. That's very clear now. Thank you so much for that.
Good. Thank you very much for volunteering, and you've done quite good work. We have covered at least 2, 3 scenarios in this. First scenario is just a simple UTI presentation, risk factors, various features of E. coli, which can be the reason for the commonest infection in a woman. Second scenario of recurrent UTI. Third scenario of a patient presenting with sepsis that can be used for any sepsis. It could be like an infection secondary to a penile prosthesis, infection secondary to TURP patient, post-TURP, and infection presenting due to high pressure chronic retention. So you can extrapolate the sepsis 6 and sepsis protocols to various scenarios. And the fourth scenario, which is very specific to the infection table, which is Xanthogranulomatous Pyelonephritis. The CT scans were very characteristic and histology also very characteristic, and good job and well done. For the students who have joined us in the YouTube channel, please feel free to click the left link for our very commonly viewed video. The central link will take you to the subscribe button. I'm sure most of you have subscribed already. The leftmost link will give you access to our playlist, which will give you all the videos done for urology exam preparation.